Honorable Vice Chancellor of SBV University, Professor Subhash Chandra Parija, Honorable Vice Chancellor of Sikshavo Anusandhan University, Bhubaneswar, Orissa, Professor Ashok Mahapatra, esteemed senior faculties, colleagues, friends, and students. Good afternoon. Myself, Dr. Giridharan, Associate Professor from Department of Cardiology, take immense pleasure in inviting you all for this SBV Connect webinar on balancing research and healthcare in cardiology at Health Sciences University. We are all very much aware of the fact that cardiovascular diseases are the most common cause of mortality worldwide. But the important thing is in country like India, which is a low income or a middle income country, the mortality rates are skyrocketing in the last decade, whereas the mortality rates are showing a decline in the Western well-developed or advanced countries. The frightening thing about the epidemiology is that in Indians, the coronary artery disease happened a decade earlier, and the case fatality ratio is also quite higher compared to the Western counterparts. Among patients who die because of cardiovascular diseases in India, close to 50% of them are less than 65 years of age in the productive age group, whereas in Western countries, it's only close to 20%. Hence, in the coming decade, when there is going to be a serious CV epidemic that's going to engulf India, there's going to be a lot of young people in their productive age group who are going to succumb to this disease. Hence, there's an urgent need on behalf of the healthcare system and administrators to identify and address the barriers that prevent the underprivileged section of our society from getting appropriate cardiac care. Secondly, there is also an unprecedented need to develop preventive cardiology as a new specialty, since these cardiovascular diseases can much be prevented by addressing the modifiable risk factors at an early stage, either through lifestyle modification or if needed through guideline directed medical therapy, which can translate into a reduction in mortality events. Keeping these things in background, two topics have been allotted for today's webinar. Session 1 will be about identifying and addressing barriers to equitable access to appropriate cardiac care. Speaker for this session is our Honorable Vice Chancellor, Professor Subhash Chandra Parija. Our professor is an eminent academician, great teacher. He was my teacher too in JIPMA. He's an erudite microbiologist, researcher, keen votary of medical education, and able administrator. He was a former director of JIPMA. He has authored 16 books and published more than 400 papers in international and national journals. Professor has been listed among top 2 scientists globally in the field of tropical medicine. He is a WHO expert member on foodborne parasitic diseases, and he had received Dr. B.C. Roy National Award in 2003 for his nodal contributions to the development of medical microbiology. And Professor is the founder of the Indian Academy of Tropical Parasitology, and he had been conferred with various fellowships such as FAMS, FACI, etc. I request Honorable Vice Chancellor, Professor Parija sir, to take over. Thank you.
Thank you very much, Dr. Giridharan, for having a nice background for today's interesting webinar on balancing research and healthcare in cardiology at Health Science Universities. Am I audible to you all?
Yes, sir. Yes, sir.
So at the outset, on my behalf and behalf of family of Sri Balaji Vidyapith, popularly referred to as SBV Pondicherry, and our Chancellor, Sri M.K. Rajgopalan, I extend a hearty welcome to all my dear participants, and particularly Professor Ashok Mahapatra, esteemed Vice Chancellor, Shiksha व Anusandhan University, Bhubaneswar, Odisha. Today, I shall be sharing my thoughts on identifying and addressing barriers to equitable access to appropriate cardiac care. That's good. That's good. Can you see if there is not moving here? So I'll be discussing about various aspects on identifying and addressing barriers to equitable access to appropriate cardiac care. It's not moving. It's moving. It's moving? Yes, sir. No moving?
It's visible, sir.
Yes, sir. It's moving?
It's moving, sir.
It's moving,
Okay,
sir.
fine. No problem. So I'll take around 20 to 25 minutes to share and some thoughts about what is about the cardiovascular diseases, about the cardiac care for that cardiovascular diseases, and what are the barriers to access this serious disease care and the challenges we face to appropriate cardiac care. As all of us know, surviving cardiovascular disease sooner depend. It doesn't depend on who you are or where you are, but too often it doesn't. Cardiac death is one of the leading cause of death of globally, and an estimated 17.9 million people die every year from cardiovascular diseases. Such is the mortality of the non-infectious disease such as cardiovascular diseases. And unfortunately, of this 17.9 million deaths which occur globally per annum, nearly more than 3/4 of this death occur in low and middle income countries. This is mostly due to lack of access to more effective and equitable healthcare services in cardiac crisis. So if we try to identify what are various barriers to appropriate cardiac care that has contributed to such a large number of mortality and also morbidity, there might be many factors, but some of the most important glaring factors that starts out is the poor infrastructures in terms of delivering cardiac support care and high expense for meeting these cardiac cares and shortages of experienced manpower. This components are aggravated further by the available health workers for support of cardiac care. They are inequitable distributions. And again, high quality of medicines and lack of innovative technology to manage this cardiovascular cares. So there are many challenges one faces in healthcare delivery for this cardiac care. That could be awareness pertaining to access, absence, affordability, or accountabilities. Now, first component, that is the challenges confronting equity in access to cardiac care. There is a huge shortage in the availability of trained workforce, particularly for healthcare research in India, that particularly with reference to the cardiac care. The shortage of a trained workforce is observed at various levels of healthcare, including specialists, primary care physicians, or frontline healthcare. And moreover, there is uneven distributions in numbers and quality of the healthcare, not between the rural and urban areas, but also between and within different regions and states. There is a gross inequitable distributions of this trained manpower, and particularly for the management of the cardiac care. Hence, improving the human resource capacity for the prevention and control of CVD remains a national priority. And furthermore, equitable distribution of trained available resources in both rural and urban setting is another challenge. So there are various ways which one can suggest to overcome these problems related to equity in access to quality cardiac care. Depends on many pillars. One is adoption of cost-effective case management for cardiovascular diseases, especially in secondary and tertiary care setting, is a most important priority. This should be supplemented by quality improvement initiatives and priorities for the continuous quality monitoring and improvement for this cardiac care. And that can be monitored and evaluated regularly by regular performance audits to identify key issues related for assess of the quality cares, supplemented by the feedbacks. Now, when we talk of the word access, what access means? Oxford definition of access means the right or opportunity to use or benefit from. Hence, to access the facilities for cardiac care, physical reach is one of the basic determinants of access defined. And that physical reach is defined as the ability to enter a healthcare facility within 5 kilometers from the place of residence or work. Again, second factor, in addition to the access to these cardiac care facilities, is further aggravated by the absence or inadequate human powers for the cardiac cares. While private sectors is nearly playing an important role for most of the healthcare expenditure in the countries, the state-run health sector still is the only option for most of the rural and peri-urban areas of the country. Then third important component is the affordability or cost of healthcare. Questions frequently raised due to increased cost of this cardiac care. How many can afford the cost of cardiac health care is an important issue. Public sector definitely expanding its role and playing an important role by offering health care at low or no cost. But sometimes is not dependable. And another component that aggravates further is the wasteful expenditures. Often we demand high spending, unnecessary use of tests and procedures. And third important factor is the accountability. That's one of the major hurdles. Being accountable has been defined as the procedures and access by which one party justifies and takes responsibility for its activities. And ethics also plays a crucial role. Hence, for augmenting and implementing a sustainable infrastructure and creating a manpower with expertise, there is a need of implementation research. By that I mean, this concept of implementation research is a discipline which studies how to choose and support various implementation strategies to get evidence-based interventions for cardiac problems into practice. This is particularly of high relevance in providing cardiac care. And this implementation research provides a concept or methods and tools to plan, adapt, evaluate, and spread improvements in the health of vulnerable populations at risk to suffer from cardiovascular diseases. This implementation research further identifies the contextual factors that serve as facilitators as well as barriers to improve the implementation barriers. Hence, these factors to be addressed to reduce their impact by creating and strengthening a health system or through various implementation strategy in line with our National Health Policy, Government of India in 2017. Now, after knowing few of the main barriers that hinders the successful implementation of healthcare in cardiac disease, how we should address the barriers. Barriers to equitable access to appropriate cardiac care are managed at different levels, starting from global level to national level, from ending in the individual levels. Obviously, strong leadership is the most important role component that is envisaged at the national level, supplemented with economic growth, facilities for decentralization of decision making, and appropriate budgeting of national health care, and strong policies supported by well-defined strategies. These are the various components of the strong national level for the management of this cardiac care. And when we talk of international level or global level, three important components that influence or constitute is the international policies, recommendations, and donor funding priorities that contribute a lot for making the policies at the global levels. In addition to this national and international level, there are many other factors which influence to equity in access to cardiac care. That includes creation of policies and guidelines, culture and practice of stakeholder management, and coordination of partner. And the most important is the challenge for implementation at community and individual levels. This is influenced by various factors, starting from cultural practices, religious beliefs, and particularly socioeconomic status, and education of the vulnerable patient, and moreover, trust in the health system that delivers appropriate healthcare in cardiovascular system to appropriate healthcare. With this background, fortunately, there has been a lot of initiatives of the Indian government that provides greater efficiency and equity in the delivery of health services. And as the government of India has announced its commitment to advance universal health coverage through shared plan. Just to give you an example, the state of Andhra Pradesh has initiated a joint venture with private insurers, public-private partnerships to provide health insurance to the general populations. Similarly, many policies and programs that impact cardiovascular health covers a wide range of areas beyond the healthcare domains, need not be confined to the healthcare domains. That includes development, economy, infrastructure, and so forth, that contributes indirectly to the systems. Therefore, research on social determinants of cardiovascular health needs to be promoted to positively by influence policy decisions. To conclude, the main challenge to provide equitable, accessible access to appropriate cardiac care involves many aspects, many components. The epidemiological transitions in cardiovascular diseases play out differently in different regions of India because of varied economic development, growth. Hence, one needs to address the social determinants that are strongly linked to cardiovascular risk factors and to the related morbidity and mortality. To overcome challenges, there is not a single strategy that can be effective. There should be multiple innovative strategies needed to limit, to halt the progression of the cardiovascular diseases, particularly epidemic and resource-poor settings. This would definitely play a crucial role in equity to access as the country progresses along the directions of epidemiological transitions. Other risk factors that makes the vulnerable population to CVD may also in future do similar social commitments. Definitely, the rising cardiovascular disease burden and thereafter the damaging consequences and complications affects many. It affects not only individuals, family, and populations, hence required urgent attentions. Yeah. In essence, to address the socio-economical differential in the burden of the disease and healthcare needs in India, there should be mobilization of more resources towards applying the existing knowledge and expertise to treat and manage this cardiovascular disease, particularly epidemics. Thank you. Thank you very much for your patience hearing.
I thank our Vice Chancellor for his elaborate speech on ways to improve access to healthcare and reduce the structural barriers in our healthcare system, as well as in addressing the social and economic determinants that prevent people from getting their appropriate healthcare, particularly the cardiac care, and also on how to address these barriers at each level, starting from an individual person to global level. Any questions that can be sent through the Dropbox after the second presentation? We may take the questions. Now we'll move on to the second session. Second session is about preventive cardiology as a dedicated clinical service, the past, present, the future in Health Sciences University. And the speaker for this session is Professor Ashok Kumar Mahapatra, Vice Chancellor, Shikshavu Anusandhan University, Bhubaneswar, Orissa. Professor has completed his MBBS in 1975 from MKCG Medical College, Behrampur, Orissa, and did his master's in neurosurgery from All India Institute of Medical Sciences, New Delhi. His interest include pediatric neurosurgery, head injury, and skull-based surgery, among others. Professor has carried out more than 30 research projects in the last 40 years and authored close to 900 papers, chapters, and books. He had been headed various posts like the head of Neurosciences Center and Dean Research, AIMS, New Delhi, and he was a former director of AIMS, Bhubaneswar, former director of Sanjay Gandhi Postgraduate Institute, Lucknow. Professor has won several awards, including Gold Medal in Pharmacology and Dr. Gio V. Desa Gold Medal for Research in Neuro-Otology. He was also awarded the prestigious Dr. B.C. Roy National Award in 2007 in the category of Eminent Medical Teacher. So over to you, sir.
Thank you very much. Good afternoon. Jai Jagannath.
Jai Jagannath.
I send my greetings from Odisha to Pondicherry and pray Lord Jagannath to bless you with good health and COVID-free life. Today is a very auspicious day that we are talking about preventive cardiology, one of the burning topic of the country and all the world. When you talk about preventive cardiology, we had a very strategic and very educative lecture by Professor Parija. I thank him for his brilliant lecture. I also thank him for giving me this opportunity to speak. In this occasion, I must thank the Chancellor, Dr. Gopalan, and also the Associate Professor of Cardiac Surgery, Cardiology, Dr. Girdharan. I think preventive cardiology is a very important part because cardiovascular diseases are the number one killer of the world. And if you look at the epidemiology of diseases and the death pattern in the world, the number one death is because of MI or cardiovascular disease, that is coronary artery disease. Second is stroke. Third is cancer, and rest follows. So if you look at the disease pattern in India, we have not given up communicable diseases and also acquired non-communicable diseases. So we all say prevention is better than cure, but when you come to preventive aspect, we put either deaf ear or a blind eye. When I was in Sanjay Gandhi, the chancellor, the governor of UP said, I would like to have a preventive checkup. I said, what do preventive checkup means? He said, every 6 months I do my TMT and ECG, chest X-ray, liver cardiac profiles, lipid profiles, liver function test, kidney function test, everything. So I said, we have no concept. So I started in Sanjay Gandhi a preventive checkup clinic and also started executive health checkup at a cost of 1,500 rupees. That include all investigation, including upper GI and lower GI endoscopy. At AIMS Bhubaneswar also, I started a preventive health clinic in 2012 and also had 2,500 rupees for preventive health checkup. Here I must tell you that many category of people in India have health checkup 6 monthly. They are either the IS, IPS, allied officers, or the defense persons who above the 40 years of age have to have preventive health checkup so that they get their next promotion or get increment. So we know that this preventive health checkup happens in India in government services. It is compulsory, it is not obligatory. When I was Sanjay Gandhi, I told my faculty, about 100 or 20 faculty, that we should have health checkup for our faculty. You know what they said, faculty meeting? Director is making all our faculty unhealthy so that we have to have health checkup 6 monthly. This is where I feel we cannot educate the educated people. They are too much educated to understand what is preventive health checkup. After having said that, I must say that we have not made a much dent in communicable diseases, but we have acquired the lifestyle related diseases like hypertension, diabetes, blood pressure, cholesterol, overweight, smoking and alcohol. When I give a lecture on prevention of 2 dangerous diseases like stroke, that is brain hemorrhage or ischemic stroke, or myocardial infarction or coronary artery disease, I say the diabetes is like Ravan and the hypertension is like Kumbhakarna. Because 2 brothers are there with 1 person, they will kill him within 20 years, believe or not. So we are really in a great problem because we have a lot more cardiac disease. When we were resident or we are MBBS student, we are talking about either valvular disease of the heart or we are talking of rheumatic heart disease. Today we don't see those many rheumatic heart diseases, but we still see some valvular heart disease. So in younger age group, still we have to have the congenital heart disease, cyanotic heart disease, valvular heart disease, and also rheumatic heart disease. When you come to the elderly age group, we have vascular problems, we have myocardial infarction, we have electrophysiological related the disease. So we have two distinct type of cardiac disease where you may have to contribute to some extent to prevent it. So in India, if you look at the total death in a year, it is about 24 to 24.8% die of either of heart problems, maybe congenital, maybe cyanotic, maybe acquired like rheumatic heart fever and heart problems, and also because of MI. So MI is the greatest killer of the world, and it is followed by respiratory disease, stroke, tuberculosis, cancer, and GI disorder. So the question is that where do you have do there something to prevent the disease? If you look at the cardiovascular disease in India in 1990 and last 30 years, what has happened? The disease burden has become 2.26 lakh million to 4.8 million. So it is almost more than 200% increase in cardiac disease in India in last 30 years. There we have to have huge number of medical personnel, infrastructure, hospital, and ICU. This is where the entire preventive aspect can help tremendously to prevent the disease. So if you look at the rural population and urban population, there is a tremendous difference between rural lifestyle and urban lifestyle. That is the reason the range of cardiovascular disease can range very high from 1 to 13%, and that varies because of different location and lifestyles. So if you have to look at the cardiovascular disease in US, it is about 6.9 lakh people die in 2020. So it's a huge number of deaths in US, even they have got money, resources, and manpower. So it's sometimes you have to be doing much more than that of only making doctors and hospital. So we know that a coronary artery disease or a cerebrovascular accident, before the ischemic event occurs, the artery takes about 15 to 20 years to get blocked. So it is a slowly progressive obstructive disease of artery which kills the individual. So it is not overnight disease like brain hemorrhage due to hypertension. So when you talk about the ischemic heart disease or ischemic brain disease, it's over a long period. Similarly, aortic disease and peripheral vascular disease also for a long lasting problem. So here the disease give a chance to prevent it by changing or modifying the disease creating etiology. So if you try to modify the disease process, you can have a long life or normal life. So what you do not do after having known, here I say that when I do the health camp in the school children below 15 years, 15% are hypertensive and 15% are pre-diabetic. When I take health camp for the elderly citizen, senior citizen, retired persons in Bhubaneswar and nearby rural areas, I see 25% hypertension, 25% diabetes, 40% overweight, and between 60 and 70, only 12% are healthy. In India, only 12% are healthy.
We are not able to see your screen.
My slides are moving.
No, sir, no, we are not able to see it, sir.
From your side, anything wrong? Can you see my photo?
Yes, sir. We can see your video.
But why you have not seen any? You have not seen any slide?
Ah, yes, sir.
What
thing we are seeing is the launch meeting, the Zoom app logo with launch meeting. Only we're able to see that.
My slides are. You just see whether have you done the screen sharing. From your side, have you done the screen sharing?
No, sir. From our side, we haven't shared the screen.
Otherwise, my slides are moving.
Stop it and reshare it again, sir. That's one thing that can be done.
You have not seen my photo?
Photo we are able to see, sir. Yeah, we are able to see it now, sir. Yes, sir.
Slide.
Yeah,
So
yeah.
we'll start from the first slide again quickly.
Yes, sir.
Not necessary. Go but first slide because I have gone up to 10 or 12 slides. Okay, quick. Okay, these are the prevent. Okay, next. Okay.
Yes, sir. It's moving now, sir. Yes,
I
sir.
was so. What is the planning? Planning is to you have the terms of references in Government of India. We say TOR, terms of reference. What is the disease burden? What are the etiological pattern? What is the geographical distribution? And how to prevent it by multi-pronged, multi-specialty approach to the cost, the load, available resources, available manpower, and available money. So when you plan for anything, the large number of factors help for planning. So whether you talk about MI, atherosclerosis, dyslipidemia, these are all disease pattern. And if you add it, that will be total disease burden, and you can find out incidence and also prevalences of coronary artery disease or any cardiovascular disease in India. It's a very huge number. So how you prevent it? Prevent blood pressure, prevent reduce BMI. We know that India has about average obesity people about 30%. In Odisha, is a poor state, but we have a overweight people about 32%, and in Kerala is 33%. So obesity, hypercholesterolemia, hyperlipidemia is also very important. The BMI is high, so that has to be worked. We have to reduce stress. People say there is stress from life to death, birth to death. Yes, we know there is stress. So we have to find out doing either pranayam, doing meditation, by cooling down ourselves. So the stress is a very important factor for diabetes and blood pressure. Lipid lowering substances. We know the large number of countries has got lipid clinic. They have got OPDs where everybody talk about how the lipid causes problem in the heart. There are awareness program. There is a special clinic run in the cardiology OPD. So there are drugs we know, and large number of study, whether Scandinavian study or lipid clinic of US or American Heart Cardiological Association, American Heart Association, they have all shown that hyperlipidemia is one of the very high risk factor, and one can reduce the cholesterol. You can reduce to some extent the heart problems, cardiovascular disease. So risk factors are also can be genetical. It is related to the many new genetic mutations of regulation of proteins, and also the factors which is maybe associated with congenital problems. So we are not going to details of the family problem, genetic aspect, that too much to talk about, because but we can talk about food quality, life pattern, lifestyles, domestic stress. We all know during pandemic, the job loss, the people are not going out, they are not able to meet the people, there is no networking, so there is stress and family violences increased. In this situation, the heart rate, blood pressure, and also many diseases are distress and depression, anxiety state of increase. So these are all causes of causing hypertension. Nowadays, we find the quality of air. We know in Delhi, air pollution causes 50,000 deaths per year every year, and cost about $50 billion loss to Delhi government or in India. So we know water pollution, air contamination, quality of food, whether cholesterol rich food or very high caloric diet, it is trans fat, and lack of exercise and not having enough rest. So there is huge number of lifestyle changes, and we have known that even the school children during pandemic are not sleeping up to 2 a.m. They are taking a lot more food, as they are all the time awake in the night and got fat. I every day see the problems of childhood because of pandemic. So we have large number of study to see what can be done to reduce stress, reduce cholesterol, how to educate people to have a normal BMI, and also do exercise, at least walking 10,000 feet a day or about 3 kilometers a day. So there are a lot of factors which can be modified. They are called modifiable risk factors. We can reduce our cholesterol intake. We can change our food habit. We can do our exercise, and we can reduce weight with a working and rest pattern. So if you can do something like that, this modifiable risk factor, you can have very highly preventable heart problems. So there are also non-modifiable problems. So we do not go to have that congenital problems or the genetic factors or up and down regulation of different protein in the body, that we have very little control. So if you talk about other risk factor or risk assessment, when you talk about any disease, we talk about risk assessment. So any disease comorbidity and also biochemical changes and also imaging technique and functional test can also tell you what is the disease risk. There are a lot number of scoring. If you give scoring to each factor and add them, you can always tell somebody is high risk, moderate risk or low risk. So we can say disease modifying factors are comorbidity, which can control them, prevent them or treat them. You can have a far better outcome so far the cardiovascular diseases are concerned. Here is the lifestyle again: exercise, diet, weight, stress, alcohol, smoking. These are all can be modified and can control by preventive method like educating people, awareness program, give lectures, doing camps, all these things. And biomarkers are too many. So we are not going to do a large number of biomarkers that are non-modifiable. So if you see the recently what has happened, there are different training to take education. So you have got preventive aspect, you have a preventive aspect at individual level, at a community level, at education level. Then you come to hospital where you are service oriented. I told you that hospitals have preventive health checkup clinic, they have lipid clinic. Every person comes to OPD, they ask about BMI, ask about what is cholesterol level, what is triglyceride and low density lipoprotein. So we have to also have this. For that, you require a lot of educated people in the form of manpower, nursing people, technician, and also social worker. So to prevent the cardiovascular disease, one can have a community-based practices and other is hospital services practices. Hospital will be health checkup clinics and also clinic where the people have to be educated by community nursing personnel, social worker, and also personnel, those who educate them for doing every 3 monthly or 6 monthly checkup. And we know most of the common death of cardiovascular disease in India between 50 and 60 years. Yesterday, our Institute of Life Science director found dead in a hotel in Assam. He had gone to Guwahati for a conference and found dead in Assam. Today, his dead body must be coming by air. So we know people can die in the sleep because of heart attack, massive heart attack during the night. So this is the opportunity for us to do lot of preventive aspect, lifestyle changes. So we require lifestyle expert. We have proper nutritionist so that what type of diet to do. Large number of people do not understand what type of food. We all teach balanced diet. Yet most of us eat junk diet and lot of fat and trans fat. So we have to need a lot of nutritionists to advise us what type of food we have to take. Again, counseling is very important. For counseling, we require social worker, nutritionist, and also a community nursing person who has to be trained in cardiovascular disease. Unless we have educated personnel, we cannot really prevent, because the busy clinician, whether the medicine specialist or a respiratory medicine specialist, even cardiologist, they see 50 to 100 patients in a clinic. So they will not be in a busy clinic and advise, counsel, or give proper preventive care to a person who comes for a treatment. So we have to have people in this large number of centers in the world give diploma, MPhil in the preventive cardiology. Unfortunately, I don't think that DM preventive cardiology yet started in India. So we have to target our general practitioner, vascular surgeon, cardiologist, medicine specialist, junior doctors, paramedics, dietitian, and healthcare allied subjects. So unless you have a large number of capacity building, we will not be able to run effectively cardiovascular preventive clinic. So the many centers in the world now have started giving degrees and diploma in preventive cardiology. It could be diploma, degree, and there are 120 credit points given for a full degree courses in preventive cardiology. in Western countries like US, Western Europe and Canada, they have degree in preventive cardiology, and that is it's very, very important to prevent cardiovascular disease. So they have first year courses, preventive cardiology, second year courses, different module. Then they teach about lipid metabolism and lipid clinic, the management of lipid disorder, hyperlipidemia, hypertension, diagnosis, management, preventive aspect. Large number of courses are given over a period of 2 to 3 years, depending upon you want a preventive cardiology or preventive cardiology diploma or a degree course in preventive cardiology. These are the education at highest level. But what you need are social worker, social guide, nurses, community nurses, cardiovascular nurses, and also the nutritionist to give proper advice for the nutrition. If you look at the medical community, large number of doctors. Yesterday, somebody came to me and said, "You are advising like this. Look at the doctor community; they are overweight." I say, we cannot educate our educated doctors. So if a doctor is overweight, I have no treatment for him. We have to only say, God helps him. So we have different courses, I told you. So these courses are very, very important if you want to prevent heart disease, most likely our lifestyle related disease, like lipid related disease, like hypertension, diabetes related heart problems. So the American Journal of Lipid Association, American Journal of Cardiology, American Association Preventive Cardiology, the large number of trained personnel through their association go for the awareness program and teach the public in America. Yet, America gets about 9 lakhs of people dying of heart attack every year. So we have to do our best to see that our young people do not die. People during 50 and 60 do not die. So in our country, we must take all steps to have prevention of heart disease at the community level, at the family level, at the school level, at the senior citizen level, at the hospital level, where it is a service care providing center. So if you talk about how the service caring center can provide preventive cardiology, I say every medical OPD, every general OPD, every cardiology OPD should have a preventive cardiology clinic, at least trained nurse, a nutritionist, and a social worker who can motivate people, can counsel people, who can give the nutritional advice, and also sisters can check over things. So if you in UK, if you go for a course like preventive cardiology and you have to go from India, you have to ELTS scoring of 6 to 6.5 out of 10. So you require high scoring to go for a preventive cardiology clinic or training in outside India. So these are different centers in the world to give degree for preventive cardiology, whether Wake Forest University or it is Portland University in USA, or it is any centers. Many centers in Europe and America have got courses in preventive cardiology. I think what I want to trying to tell you in last 20-25 minutes is a very important part of our disease pattern and disease burden. Large number of people die of cardiovascular disease, and that is the #1 killer of the world. There are large number of factors which can be modifiable and preventable. That include hypertension, proper control of diabetes, proper exercise, prevention of overweight or obesity, reducing the cholesterol level. If you are smoking, stop smoking. You are drinking, stop drinking. Do proper exercise. Then you have a pranayam. You also, for keeping stress level low, do the meditation, pranayam, exercise, proper diet, work and rest pattern. If you do all these things possible, today you can still have a healthy life. I have seen a lot of people in Bhubaneswar surviving 90 years without hypertension, without heart disease. But coronary disease can be also a disease in the old age. Without any risk factor, there could be slow narrowing of the coronary artery or the brain arteries like carotid artery, and it can be stroke. If it's disease-related blockage of artery, for that you cannot have preventive checkup. But if it's a modifiable factor-related disease, you have to have all these modified factor properly looked after much before the heart attack or brain hemorrhage occurs. I told you that average span between a At coronary artery to get blocked is about 10 to 15 years. So if we take really preventive steps, either we can change the disease pattern or we can prevent the coronary artery disease, coronary vascular accident or cerebrovascular accident, or even peripheral vascular disease, which is related to smoking, alcohol, overweight, and large number of other factors which are by and large modifiable. So I think we'll stop here and take some questions, because I think these are very common factor most of our people know. Yet what is very common is very uncommon or very difficult to practice. If you tell overweight people, somebody come to my clinic 85, I made it a practice to tell everybody reduce your weight. They say, sir, we have not come to hear that reduce the weight. I was 90 kg and I have reduced 5 kg to 85. What do you want? I say you become 55 or 60. So they just laugh and go away. So as if we are talking something which is out of their head or they cannot go through their heads. So it's very difficult to educate. But if he's a farmer, those who are working in the field, that is the reason I said in urban and rural difference is always there. I think we'll stop here. Thank you very much. I thank Dr. Parija and also your university for giving an opportunity to speak. Dr. Giridharan, it's wonderful to talk to you. I made my slide because if I thought I'll take your slide, the question, when I read my slide, I make my slide, I read several times, correctly several times, and I learn myself. So even though I have created 3 places, the preventive clinic, it is still then I also tell a lot more things to do. It is not only the government, it is the community level, the hospital level, medical college level, and administration level. Thank you very much.
Thank you, sir. Sincerely thank Honorable VC sir for enlightening us about the need for preventive cardiology as a dedicated subspecialty in the field of cardiology, its importance, the way to handle risk factors, how to modify these risk factors as early as possible before some irreversible pathology can happen in the coronaries, and as well as the associated fellowship programs where preventive cardiology can be studied. Thanks, sir. Thanks for providing all this data. Since we don't have any questions as of now in the chat box, if it's okay, we can conclude the session, sir.
No problem. From my side is okay. I think most of the things we said, people know it.
Yeah.
But whatever you know, you don't follow it. That's the difference between a good human being and a Hippocratic human being. Bhagavad Gita says hypocrisy is nothing but deluded intelligence. But in deluded intelligence that we are not really intelligent, behave as if we are super intelligent like supercomputer. So the person who cannot think of their own good, how can he be intelligent? So here the hypocrisy word is very, very appropriate. And that I learned from Bhagavad Gita. Thank you.
Thank you. Thank you very much, Professor Mahapatra, for your wonderful wisdom. So here in this cardiac disease, preventive, and you are talking so nicely. Many of these things are known, but I think such programs that need more re-emphasizing.
Absolutely.
This point
Absolutely.
repeatedly, so that sometimes some may follow it. Thank you.
Our doctors to be educated fast. If we prevent heart attack, 3 of our staff have died in last 1 year.
Yeah.
One from our news item, other is from our store, one is our technician in the lab. They're all between 40 and 45, not in 50.
Yeah.
So 3 people have died in 3 months in our university. They're between 40 and 45. So it can happen, no doubt.
It can happen anywhere. It does not speak about a position or.
Dr. Ajay Parida.
Yeah, I saw yesterday news that.
Who had done a lot of work in genetics of the COVID-19.
Yes.
Genomics. He died in the hotel of Assam. So sad. It's very active person. Let us pray for his soul.
So thank you very much. We'll close it. Nice meeting, and we welcome you again next meeting. Thank you, Dr.